In a prior episode of Quick Takes, we talked about patient Eliza, a 60-year-old woman with new onset of depressive symptoms 6 months after suffering a myocardial infarction. We wondered how to accurately diagnose depression in Eliza given her medical comorbidities, and we also talked about the safety and efficacy of using an SSRI in someone with a cardiac history like hers. We learned that among medical conditions, the effect size for SSRIs is actually highest in patients with myocardial infarctions, and that SSRIs are safe and well tolerated in this population. This month, we examine the other side of the coin. What about the cardiac risk for patients newly diagnosed with a psychiatric illness? Are they at higher risk for cardiovascular disease as a result of their psychiatric diagnosis? In other words, is the relationship between heart disease and psychiatric illness bidirectional? A new study using databases from 3 countries, including a cohort of over 900,000 subjects with psychiatric diagnoses, confirms that psychiatric illness does increase the risk for cardiac disease, and importantly, suggests that the risk is independent of familial factors. I'm Scott Beach for the Psychopharmacology Institute, and this is Quick Takes. The subjects in this study were newly diagnosed with psychiatric illness between 1987 and 2016. The authors also examined cardiac outcomes in their more than 1 million unaffected siblings, that is, unaffected with psychiatric illness, as well as in age and sex-matched populations in a 10-to-1 ratio. Compared with siblings and these other matched controls, patients with psychiatric disorders experienced higher rates of cardiovascular disease. Importantly, the effect was highest during the first year after psychiatric diagnosis, but persisted for up to 30 years. The effect was noted in both men and women and across all age groups. Direct links were found between psychiatric disorders and risk for hypertension, ischemic heart disease, venous thromboembolism, angina, and stroke. Among psychiatric illnesses, patients with anorexia had the greatest risk for cardiovascular disease, and only autism spectrum disorder patients showed no increased risk, likely due to their average age of 12 years at diagnosis. Now, many prior studies have found links between having a psychiatric disorder and being at a higher risk for cardiovascular disease. So, in some ways, this isn't new information. The association has been shown for patients with major depression, generalized anxiety, and panic disorder, and for cardiac outcomes ranging from hypertension to MI, from stroke to heart failure. Some of these associations are very well established, like for depression and acute coronary syndrome, whereas others have had more mixed results, like anxiety and heart failure. Nonetheless, it is generally accepted that psychiatric illness does increase the risk for bad cardiac outcomes. The big question has been why. Lots of theories have been put forth about why these associations might hold true. One idea is that there is a direct causal link. Perhaps psychological distress leads to things like autonomic dysfunction, inflammation, endothelial changes, and platelet aggregation, any of which may directly cause bad cardiac outcomes. An interesting example of this occurs with a phenomenon known as Takotsubo cardiomyopathy, which is also known as broken heart syndrome. Patients with Takotsubo cardiomyopathy experience an acute ballooning of the apex of the heart that mimics a myocardial infarction and can be fatal, but is often reversible. This occurrence is thought to be related to a catecholamine surge and often occurs in the setting of acute psychological stress. Cases have been reported in the setting of the death of a loved one, divorce, and even the loss of a sports match. It's one of the strongest examples of the mind-body connection. If patients experiencing acute distress can have such significant cardiac changes, it would follow that patients experiencing constant heightened levels of distress, as in major depression, might also experience an increased risk for cardiac disease as a result of direct effects of depression on the body. Another theory between this link is that mediating illness or behaviors may also be important. For example, patients with generalized anxiety disorder have higher rates of tobacco use, diabetes, and high cholesterol. And perhaps these factors drive the increased risk for cardiac disease. Similarly, depressed patients are more likely to have poor health habits, like lack of exercise, and less likely to adhere to medical recommendations. Perhaps it is these factors and health behaviors that drive the increased risk, rather than the psychiatric illness itself. And then a final theory has held that perhaps patients with psychiatric illness have genetic or familial factors that also increase their likelihood for cardiac disease. In other words, perhaps there is an underlying factor that is driving both psychiatric and cardiac illness. The big importance of the study we are discussing today is that it controlled for familial factors by including siblings without psychiatric disease, and showed that those individuals have about the same rate of cardiac disease as the general population. This provides evidence against the idea that some underlying genetic factor is increasing the risks of both psychiatric and cardiac disease. That's really important as it helps us to narrow our focus in linking these conditions. Finally, in addition to recognizing that our patients are at higher risk for cardiac disease, it's also important to keep in mind that patients with psychiatric illness have higher rates of morbidity and mortality as a result of that cardiac disease. Depressive symptoms after an acute coronary syndrome, for example, are associated with significantly higher rates of morbidity and mortality over the subsequent 5 years. And the American Heart Association considers depression a risk factor for adverse events following an MI. One study even suggested that every point on the PHQ-9 increases the risk of cardiac readmission over the next 6 months by 9% for patients with major depressive disorder who are hospitalized for cardiac illness. Combined with a finding in this study that the risk of a new cardiovascular illness is highest in the year following diagnosis of the mental illness, it's imperative that we closely monitor our patients, particularly those with new psychiatric diagnoses, encourage follow-up with other medical providers, discuss health behaviors, and advocate to our colleagues for better screening and treatment for our patients.